next minute, and then we'll do some introductions. Good afternoon, everyone, and welcome. This 1-hour Harvard University Center for AIDS Research webinar is organized by the Adolescents and HIV Scientific Working Group, led by Andrea Ciaranello and co-led by Denise Jacobson, Kate Powis, and myself. Today's webinar will feature an overview of 2 recent major health policy decisions impacting HIV prevention: Braidwood versus Becerra Management, and the decision to reject CDC ending the HIV epidemic funding in Tennessee. 2 experts will review the legal and health policy landscape of the recent Braidwood ruling: Mandisa Moore O'Neill, JD, of the nonprofit Center for HIV Law and Policy, as well as Elizabeth Kaplan, JD, of Harvard Law School's Center for Health Law and Policy Innovation. 3 speakers will then address the impact of proposed changes to HIV funding in Tennessee from the perspective of physician scientists, community-based organizations, and early-stage investigators: Ima Ahankai, MD, MPH of Vanderbilt University, Amna Osman of the community-based organization Nashville Cares, and Ethan Bore, MD, PhD of Duke University, who is also a rising internal medicine resident at Mass General Hospital in Boston. The event will be moderated by Meredith McNamara, adolescent specialist at Yale and co-founder of the Integrity Project to promote science in child and adolescent health policy. A sincere thanks to the Administrative Corps for all their assistance in getting this organized today in short order, and also to our speakers for participating today. Each of you I know personally has gone above and beyond in your professional careers to address these issues, and we are incredibly grateful for the opportunity to learn from you today. A few housekeeping items: we are using the chat function only for the Q&A. This will be recorded, and the link will be posted to the CFAR YouTube channel and will be available there. Mandisa, I'll turn it over to you.
Thank you, Anne. First, I just want to say thank you to the Harvard CFAR for engaging in this conversation. It is always very timely. So what I'm going to do is just an overview of what Braidwood Management v. Becerra is, and also some context onto what the Fifth Circuit is. I think sometimes words are used and it's like, here's some more information. And then I'm excited because Liz is going to talk about the possible policy implications. So it's a good stack that way. So who? So any lawsuit, it's always 2 sides. Plaintiffs are: 1, Braidwood Management, a for-profit, closely held organization that has health insurance for about 70 employees. It's a couple of other people, companies, as well as 6 private individuals who have come together with one objection, challenging the provision in the ACA that says, employers must purchase health insurance in alignment with certain requirements. Some have explicitly religious objections. Some don't have religious objections. In this conversation, I'm going to spend slightly more time on the not religious objections, but really I'm going to talk about both. Next slide, please. And then they are bringing suit against Xavier Becerra, who's the Secretary of the U.S. Department of Health and Human Services, who's representing the U.S. government. Now, of course, the question is, what is the basis of their claim? These plaintiffs, who again are a mixture of companies and individuals, say that the ACA's requirement that they cover certain preventative health services violates two things. One is the appointments clause of the Constitution, and for some of them, it's also their rights under RFRA, or Religious Freedom and Restoration Act. Next slide, please. So here's some background, and this is probably information like that folks know. So under the ACA, which was passed in 2010, private plans and those states that have expanded Medicaid have to cover preventative services. And this is determined by actually three different committees. One, I imagine many of us are familiar with HRSA. The other is focused on immunizations. And the other, which is really important for our purposes, is the U.S. Preventative Services Task Force. Next slide, please. So in the Constitution of the United States, it says that the president is responsible for nominating and appointing certain officers of the United States. And these are known as principal officers, but Congress can appoint inferior officers. So principals, president, inferior, Congress. So the question here are the heads of the three committees that I just mentioned, are they inferior officers, which would mean Congress has the right to appoint them, or are they principal officers, which means if Congress has actually appointed them, it's unconstitutional, just for some background. Next slide, please. So the plaintiffs claim, again, that one of the reasons why they're challenging this is because it violates the appointments clause. They're saying that the head of these committees function like principal officers, but they were appointed by Congress, and therefore it's unconstitutional. For a side note, this is not actually a new argument. It's actually an argument that those who have been opponents of the Affordable Care Act have actually had since it was first passed in 2010. Next slide, please. Unfortunately, Judge Reed O'Connor, who is a federal judge, and I'll talk about this more later, but unlike state judges who are elected, a federal judge is appointed by a president. And unlike a state judge, which has a term, a federal judge serves until they decide to retire. This particular judge was appointed in 2007 by George W. Bush. Now, what's very interesting is Judge O'Connor said that HRSA and the ACIP are properly appointed, but that the USPSTF is unconstitutionally appointed because they have too much independence. Therefore, he ruled the USPSTF unconstitutional, and therefore anything that they recommended from March 23, 2010, again, when this took effect, as void. This is potentially a national injunction on a wide range of services in A or B that this committee has recommended, including PrEP, including pregnancy screenings, diabetes screenings, cancer screenings, STIs, contraceptions, a very wide range. Liz is going to talk more about the implications of this, but it's important to know that this is not just limited to Texas or North Texas. It has implications for the whole country. Next slide, please. So that was the major part. And again, as I mentioned, some plaintiffs also had a RFRA argument, which basically was focused around PrEP. that this pre-exposure prophylaxis encouraged homosexuality and promiscuity and thus violated their rights under RFRA, which no agency can substantially burden a person's First Amendment right if there's not a compelling government interest. And this judge says there is no compelling government interest, and therefore they don't have to ensure PrEP in particular if it violates their rights under RFRA. Next slide, please. So I just said the same thing. Because it was only for those that had a religious objection, it is narrowly applied and does not apply in a national injunction as the Appointments Clause ruling did. Unfortunately, it's still very disturbing from a legal and policy standpoint in that it actually represents an expansion of the RFRA doctrine to cover what historically has been seen as neutral action on the part of the government. So not that I'm trying to be a doomsday person, I'm still very disturbed in the ruling in RFRA. Next slide, please. So in the minute I have left, I'm just going to give an overview of the federal court system. So as I mentioned, unlike state judges, federal judges, appellate federal judges, and at the Supreme Court, folks are appointed. It's not an election. We elect the person who appoints them. The Fifth Circuit is made up of actually 17 judges and 9 senior judges. It is often seen as the most as one of the most conservatives. I say it's the most conservative. Its chief judge is Richmond. It's mostly a lot of conservative presidents who appointed. For context, Dobbs was out of the Fifth Circuit. June Medical was out of the Fifth Circuit. Many of the cases that really impact people's lives, unfortunately, have come out of the Fifth Circuit. Next slide, please. Last thing I will say in the interest of time is the Fifth Circuit makes up 3 states, Texas, Mississippi, and Louisiana, and it's actually located in New Orleans. So in the interest of time, I can answer any questions later, but I hope this was a helpful overview of the facts of Braidwood, and any next steps. The last thing I will say is last week on May 15th, is this my last slide or next slide? Okay, good. I thought there was another one. The Department of Justice had requested and was granted a stay. This is good in the sense that folks have been worried about an immediate change to services, and a stay means that until a final decision comes from the Fifth Circuit, things are going to stay the same. So as of now, people still have access, but the long-term implications are definitely things that all of us should still be thinking about. Thank you. And this is some more about my organization, Center for HIV Law and Policy. Check us out at hivlawandpolicy.org. Thank you.
Hi, everyone. So I think I'm just going to jump right in, following up on Mandisa's comments, and go into a little more detail about the short and long-term impacts of this case, primarily on private insurance plans and what we could see going forward. And I'll also mention briefly how we could see some impacts on public health insurance programs and what advocates are doing in response. And again, my name is Liz Kaplan, and I am the Healthcare Access Team Director at the Center for Health Law and Policy Innovation. So as Mandisa mentioned, we don't expect any immediate changes to private health insurance plans because the decision has been stayed until the Fifth Circuit rules. We don't know exactly when that will be, but currently the average time for the Fifth Circuit to decide cases is about 9 months. So we are expecting a decision probably around the end of this year or early in next year. What that means is that we don't expect to see any private plan changes in 2023. And hopefully we won't see much, if any, changes in 2024 either, due to either the timing of the decision, which could come out so late in 2023 that there's not really time for plans to change their benefit design for next year. Or, even better would be to get a better decision from the Fifth Circuit or a continuation of the current stay. There are also some other reasons that we might not see plans make a lot of changes in the immediate term to private health insurance coverage. So one of those is obviously the decision could change on appeal, and private plans may be waiting to see where the dust settles on this case. But in addition, there are also state laws in many states throughout the country that mirror the ACA's requirements for coverage of preventive services. So private health insurance plans that are subject to those state laws and regulations must continue to comply with them. And finally, this is considered a very popular provision of the ACA. People like the idea of full coverage of preventive services. So there may be plans that decide not to make changes, at least for the short term, because they perceive that consumers like this coverage. Next slide, please. Unfortunately, looking ahead and in light of the fact that the Fifth Circuit is very conservative, as well as the Supreme Court, we are very concerned that this case could be affirmed on appeal, or potentially the decision could even be expanded. So what would be the long-term impact on preventive services? Over time, we could see insurance companies and private employers either drop coverage of the services that are recommended by the USPSTF entirely, or maintain coverage of these services but impose co-payments, which currently are not allowed under the ACA. And we know that even low co-payments can sometimes be a barrier for people to access preventive services in particular. So what services are we talking about? It's actually kind of complicated to figure out exactly which services could be impacted because of the way that the court structured its order. So the court said that instead of mandating coverage of all preventive services recommended by the USPSTF without co-payments, the court's order essentially said that the federal government cannot enforce this mandate with respect to any services that were recommended after March 23rd, 2010. Which means you have to look at whether any version of the USPSTF recommendation was in effect prior to March 23rd, 2010, what the differences are between the two versions. And also, some of the services that are recommended by the USPSTF are also recommended by HRSA for specific populations. So, and currently, the HRSA guidelines, or the mandate to cover services that are recommended by HRSA, has not been impacted by the federal district court's decision. So you have to also consider that those mandates are still in effect. So here I've listed some of the preventive services recommended by the USPSTF where coverage could be impacted. Obviously, PrEP is impacted because the recommendation for PrEP dates only to 2019. HIV screening, though, is a little bit more complicated. There were actually USPSTF recommendations in effect to cover HIV screening prior to 2010. But the new recommendations that have come out have generally expanded the population of people for whom testing is recommended. So for example, USPSTF has gone from recommending testing for people who are at high risk for HIV to recommending testing across the board. And there are current HRSA guidelines that recommend HIV testing for women. So when you put all that together, we find that there are some people for whom HIV testing might theoretically not be covered in full by their private insurance at some point in the future. Hepatitis C screening is also an area of concern because, of course, prior to 2010, the treatment options that were available for hepatitis C were a lot less effective and poorly tolerated. And as a result, USPSTF only recommended screening adults who are at high risk for hepatitis C. Whereas now screening is recommended across the board because we have much better treatment options for people who test positive. I have listed a few other preventive services on this slide that are going to be impacted, but in the interest of time, I won't talk through all of them. However, the American Lung Association does maintain a running list of affected services, including the ways that the recommendation has changed over time since 2010, if there was a pre-2010 recommendation. But just as much as we're worried about the current USPSTF recommendations not being enforceable as a coverage mandate, we're also very worried about the new recommendations to come from USPSTF not being mandated to be covered in full. For a couple of reasons. One, USPSTF has gotten better over time at writing very clear recommendations that state who should be screened for certain conditions and who should be provided certain interventions. Some of the pre-2010 recommendations are a little bit more vague. So screening for cardiovascular disease is one of those where pre-2010, it was very clear that people at high risk should be screened, but it was less apparent that certain people who are at high risk for cardiovascular disease should be prescribed statins to lower their risk. The more recent recommendations are much more clear about that. The other concern about not covering new recommendations is really a health equity concern. In recent years, USPSTF has brought a more explicit health equity lens to amending and adding new recommendations, including looking at questions like, what do we need to do to ensure that we're making recommendations that take into consideration the needs of all populations. And so by not mandating that new USPSTF recommendations get that those services have coverage, we are losing the benefit of that new health equity lens that I think is really concerning and could set us back in terms of our efforts to combat health disparities. And finally, I just want to mention all of this presumes that the decision on appeal is not expanded. There are actually some ways in which the Fifth Circuit or the Supreme Court could issue a more expansive decision undermining access to not only the USPSTF recommended services, but potentially the vaccinations recommended by ACIP and the HRSA recommended services. Next slide, please. So I want to just touch on Medicare and Medicaid very briefly, because this case is mostly about private insurance. But we could see some limited impact bleeding into Medicaid coverage, unfortunately. So in Medicaid, prior to this decision, all ACA preventive services, including USPSTF recommended services and the ACIP and HRSA recommended services, had to be covered in full for the Medicaid expansion population, and states receive a financial incentive to cover all USPSTF A and B services and ACIP recommended services in full in Medicaid. Because of the particularly expansive way that Judge O'Connor did both his appointments clause reasoning and issued his remedy order in Braidwood, we could see some of that reasoning imported into Medicaid policy, depending upon how the Fifth Circuit and the Supreme Court interprets the case and the arguments made by the parties. But I think it's really ambiguous at this time and very hard to tell. And also the impact, if any, could vary state to state because Medicaid programs are implemented at the state level. Medicare, though, is not affected by this decision because preventive services are added to Medicare coverage through a different statutory mechanism. Last slide. So what can be done about this? Significantly, advocates and medical groups and others are submitting amicus briefs to try to influence the appellate court's decision in this case. There's also, as I mentioned, there are state laws and regulations in various states across the country that import the ACA preventive services mandate to specific health insurance plans that are regulated at the state level, which is many, but not all health insurance plans. And some advocates are undertaking an effort to expand the number of states that have those laws, including here in Massachusetts. Down the line, there may also be some efforts to resolve this through federal legislation, though unfortunately, I think in a divided Congress, that's not likely in the immediate future. And there may also be some efforts by the administration to try to mitigate the harm of this decision through issuing new federal regulations. Although the administration is unlikely to take any steps of that nature while the case is still progressing in litigation. And finally, there have been some efforts to encourage employers and insurers to continue to voluntarily commit to covering these services in full because it's the right thing to do. And we have seen some success along those lines, particularly in Michigan so far. So that's another thing that advocates are doing. And I'll stop for time reasons, but happy to answer questions.
Hi, good afternoon, everyone. So we're transitioning now to talk about the HIV policy landscape in Tennessee. Next slide. So just a little bit of background about the pandemic in Tennessee. The epidemic in Tennessee. There are about a little over 19,000 people living with HIV in the state. And Tennessee has struggled with particular continuum of care outcomes, especially linkage to care, where Tennessee is the third poorest in the country with regard to linking people into care after HIV diagnosis at about 74%. Tennessee is also home to one of the EHE priority jurisdictions, and that's one of the 48 counties across the country that have been designated as a focus for ending the HIV epidemic because of the disproportionate burden of disease in those counties. So in that regard, Shelby County or Memphis is really the epicenter of our epidemic in Tennessee and has the 8th highest incidence of HIV infection for large metropolitan areas in the country. Importantly, we also have substantial racial and ethnic disparities that remain quite problematic. So for example, 17% of Tennesseans are Black, but if we look at the proportion of individuals living with HIV in the state who are Black, that's 54%. And then if we focus on Memphis in particular, that jumps to 83%. When thinking about Blacks or Hispanics or race or ethnicity, prevalence rate ratios range from 2.5 to 13.5 times higher than white counterparts, depending on the specific population we're looking at. This becomes really important because any policy decisions that impact particularly Memphis, particularly this epicenter, but across the state, are really going to further entrench those racial and ethnic disparities, whether that's an intentional or unintentional consequence of the decision and something that we need to keep an eye on. And when thinking about the PrEP landscape, the PrEP to need ratio for Tennessee is estimated at 10.7. Next slide. So this is a timeline of the events that we're going to highlight today. Amna and I will walk you through these. But starting in January of this year, we were all really surprised to hear this announcement that TDH, or the Tennessee Department of Health, announced that it would not be accepting 2 federal grants from the CDC, totaling $8.3 million after the end of this month, May 30th of 2023. And those 2 grants, one was to be awarded directly to the Tennessee Department of Health and the other directly to Shelby County in Memphis, emphasizing the point that I mentioned earlier. So some of those funds were directly earmarked for surveillance, HIV surveillance and prevention services for Memphis. Next slide. So interestingly, in the letter that was addressed to employees at the Tennessee Department of Health, it said that the state has determined it is in the best interest of Tennesseans for the state to assume direct financial and managerial responsibility for these services, which of course caused a tremendous amount of chaos and confusion. Next slide. Subsequent to that, we then heard that the state was identifying new priority populations for the focus of funds that they promised the state would disperse for surveillance and prevention activities in the absence of the CDC funds. And these priority populations were first responders, victims of sexual trafficking, pregnant women, and children. Next slide.
Thank you, Ima.
Yeah, advance once more, please. Thanks.
So in February, the state health department, the health commissioner actually officially notified CDC about the decision to reject the funds that were coming in for HIV prevention to the state of Tennessee. So during that time, of course, this was a surprise for all of us as a community-based organization that's been providing services, HIV prevention services for over 2 decades. really got surprised. And so we really deployed a lot of local advocacy and partnerships and started to have conversations about what was going on. Our CFAR in Tennessee was instrumental of really trying to discuss what would be the way to go forward about how do we really deal with this and what's going to be the impact. And really appreciated the national organizations coming together to really talk about what can be done to really fix this or to come up with some solutions. And so I say it was advocacy at its best. We really had everybody coming together, but most importantly, we reached out to clients and patients to really educate them and to really explain how they could take action and what needed to happen for their voices to be heard. And so with the great media relationships that we had and, media outlets that came to many of us in the state to talk about what was going on. And as you know, when something like this happens, you get media that is accurate, information that's accurate, and information that people are hearing because it's flowing very quickly. So just wanted to share with you some of the news stories. And so next that came up, issues around Tennessee to cut off funding to nonprofits for HIV prevention, testing, and treatment. There's also some other ones around what is happening in Tennessee and how is it going to affect the public health infrastructure and really decimate it. Funding that's going to be cut and how is this going to impact other states and especially states in the South. As Ima mentioned, HIV disproportionately affects Black and Brown folks, and the Southern Belt really has the majority of HIV cases. And so really having a robust system and an infrastructure to try to really end the HIV epidemic in Tennessee could potentially impact other states in the South. Next slide. And then really, just kind of speaks to where do we go from here, all the great work that researchers and clinicians and organizations have done and what happens as we start to move forward, and especially having an epicenter in Shelby County to really address, HIV and the majority of cases that are in the Shelby County area. And we can continue and continue. This is another article from The Body, the New York Times. We had NBC. I mean, it just goes on and on. I think I counted, we had about maybe 20 news outlets at one point. But really, most importantly, the fear that was going on with patients and clients, and how do we really educate them to understand that we need to collectively come up with a solution to move forward and to continue these services, and that clients and patients are educated. Next slide.
So one of the things that really became evident as Amna discussed as we were having these conversations and amplifying this discussion in the media is that it was really important to have clear and effective communication, but also to have some rapid analyses that could have informed this discourse. We mentioned the idea that these new priority populations were truly created and didn't at all follow, the evidence that we've been, become quite familiar with over the past many decades. So we were really grateful to organizations like AMFAR that produced this infographic in a, pretty quick manner that allowed us to be able to explain to people who are not entrenched in the world of HIV the way we are, what this type of policy could actually mean, where, focusing on priority populations that were identified might prevent an estimated 9 HIV cases per year, versus doing the tried and true, following the epidemiology and the populations who were actually at greatest risk of HIV, would allow us to prevent an estimated 509 cases per year. So it really amplified for us the importance of being able to have some accurate, informed analyses to really infuse into the discourse in this process. Next slide. So this slide really highlights just a schematic of how these funds are actually meant to flow. And it actually follows the path of really the public health infrastructure that exists as well. So for the federal dollars that are allocated for these activities flow through the CDC, to state departments of health, in this case, Tennessee Department of Health, through one large local partner, United Way of Greater Nashville, which then distributed these funds to 30 community-based organizations across the state. This is really important because these community-based organizations are the ones that have been doing the work in the community, have the trust of the community, and have been vetted over time to be sure that they are really engaging with the right populations for the right range of preventive and treatment services. So this is the way things were meant to be and had been going for many years. Next slide.
So it's really important to note that not only were the HIV prevention education dollars going to be an issue, but it was really the 340B designation that was coming out of this grant, which, you know, a lot of people across the country have probably heard about it, 1802. And so really is about what's going to happen with the designation for covered entities where STI and prevention treatment for PrEP and for other care and treatment services was happening. And so really the implications that we were really concerned about is the loss of the 340B designation, which really allowed us to provide clinical services, the loss of our personnel in the prevention education system and network. We have folks that have worked in HIV, as we all know, for decades. And so really the institutional knowledge and the training and really the trust that we have, built with the community. And also some providers that would, there'll be gaps in services around really providing clinical services that ultimately would affect health disparities and inequities that people have been dealing with for so long. And I think dismantling the HIV infrastructure and capacity is not something that I think folks thought about when you lose funding, what it does to really cripple the infrastructure and really the capacity to provide services and meet the needs of people who are at risk and living with HIV. And really the fracturing of the continuum of HIV care. Prevention education is kind of the entry point of really making sure that we are able to educate people, that people know their HIV status. 1 in 8 people in Tennessee are unaware of their HIV status. So promoting testing and if positive, being linked to care in a timely manner is really important and critical. And so really looking at the impact on a more macro level. Ultimately, in April, the CDC, with all these advocacy efforts and a lot of support from a lot of people and having conversations and knowing the impact in Tennessee, announced that they would be funding community-based organizations for $4 million. And then ultimately, the state, through the legislators, appropriated an additional $9 million locally to community-based organizations and health departments. So here we had 2 funding streams coming in, but of course we'll talk to you about some of the challenges and barriers of making sure we get these resources out, but what are the restrictions? Next slide.
So as Amna mentioned, so the CDC, in a really unprecedented move, decided to directly award $4 million US to United Way of Greater Nashville, and this really bypassed the Tennessee Department of Health. And then for those funds to be distributed to community-based organizations. The challenge here is that, as I mentioned before, the 30 community-based organizations spread across the state that have been doing the work, we're not actually sure which ones will be awarded. This is a really active and ongoing area of planning and preparation right now. And really scrambling to try to recreate an infrastructure to do this well. So this is where we are currently with the state.
So with the state appropriation, the state selected 6 organizations to receive the funding out of 30. So you can only imagine what's going to happen with organizations that don't receive the resources. They also prohibited subcontracting with any of these HIV funds. And then also covered entities were expected to serve as fiduciary, making sure that with partners who are not funded, to get them HIV testing kits, condoms, and really making sure that syringe exchange programs continue in respective regions. So not only are now providing services, but we're also acting as fiduciaries, which some of us don't have the capacity or the know-how or, to be able to really act as fiduciaries. So they're kind of emerged another challenge for us as community-based organizations. Next slide. And so I think what's really important here, we have newly created priority populations, the true populations that are at risk. How do we continue to focus on those populations and making sure that we adhere to the populations that have been identified that IMA spoke to: first responders, victims of human trafficking, women, infant, and children. And so really making sure that we look at the resources and deploying them in appropriate ways to meet the needs of the community, but also to make sure that we address the priority populations. The way that we're getting funds, it's not a well thought out plan. Funds are coming in ways that are directly appropriated from the legislator. So it's a very different funding mechanism that we have to kind of make sure that, you know, we understand. And then, of course, 6 organizations, those that are unfunded, what's going to happen to the infrastructure, what is going to happen to providing services in certain jurisdictions. And then really, I think the big piece is having subcontracting or not, with or without contracts. It's been very unclear, a lot of information coming. And with syringe exchange programs, there's legal implications. And so how do we really start to think about that to ensure that we are meeting the needs of the community, but making sure that, you know, legally that we're covered? And really data and data systems, and really making sure of how do we look at data and make sure that data is informing the programmatic, you know, changes that we're doing. And really data being so fragmented is concerning. And then the trust that we've built in the community, and now with all this kind of funding issues and lack of information that is coming at us at different ways and changing, it's deepening that lack of trust that we've built over many years with the community. Next slide.
So from the physician and researcher's perspective, we've talked about kind of this infrastructure that includes the state departments of health and community-based organizations, but also hospitals and universities. And so while we have this appropriation of resources currently, we definitely have some challenges to the tested public health infrastructure that's really removed the State Department of Health. So from the research and the clinical perspective, thinking about how data to care usually is working, that process is disrupted. And whether that's for, the state departments of health that are running the continuum of care analyses that start with testing and knowing who's positive, that process has been disrupted now with this new flow of funds. Also, for clinicians or clinical practices that liaise with the health department to understand who is out of care and help re-engage people in care, we're not sure how those systems will continue to operate. If the data, of course, we know data, for data, the integrity of the data that goes in really informs the integrity of research that we're doing. And this is important both for individual research projects, but also for the greater public health mandate of how we're doing in ending the HIV epidemic and guiding our practice. In Tennessee, our CFAR includes the Tennessee Department of Health and Vanderbilt and Nashville Cares and Meharry Medical College. So the State Department of Health is a part of this infrastructure of our CFAR. And while we know that individuals there have the best interests of people living with HIV in the state at heart, we're not sure what actually will happen to that infrastructure. And I think really importantly is the climate that this has all created at multiple levels, whether it's the community, our clients, very importantly. From the provider perspective, I know there's been a tremendous amount of fatigue and anxiety and burnout, of course, on the heels of the pandemic, which has been quite challenging. Next slide. So I think we've brought you to where we are today in this webinar, and we'll end with a couple of thoughts here. Next slide. From lessons learned and the way forward. So I think, Amna mentioned earlier that we saw some elements of advocacy at its best, which really took strong relationships between academic and community partners and public health. I think none of that would have been possible without the pre-existing relationships that will continue to need to be nurtured. But I think we also realize that we need to build effective coalitions, continue to make sure that we can navigate these new and complex relationships for how these funds are being dispersed, and to make sure the left hand knows what the right hand's doing and how we can, wade our way through the current situation. Continued advocacy will be critical. I think I mentioned earlier the importance of having some optimized rapid research landscape, which is not, of course, what we do as research. We don't usually do things in a quick manner, but we also need the tried and true research to be able to evaluate the long-term impact and implications of these types of decisions. And we need to ensure all along that we have an effective communication and dissemination at all levels that's really accessible both to policy and legislators, but also to our clients and the general community. Thank you so much. I think we'll have hopefully have time for questions at the end.
Hi, thanks so much, Dr. Onkei, Ms. Osman. I'm Ethan. I'm very appreciate the invitation to speak with you all this afternoon. So I'm going to be going through a research project that's looking at this policy crisis in Tennessee, projecting the impact of HIV prevention funding reallocation in Tennessee. Next slide. So the background was just given much more eloquently than I ever could. But, you know, Tennessee has rejected around $6 million of funding for HIV prevention and diagnosis, primarily testing, condoms, and PrEP. The CBOs are experts at prioritizing at-risk populations for HIV, such as men who have sex with men and transgender women. And the governor proposed new priority populations: first responders, pregnant people, and victims of sex trafficking. And of course, what happens in the long term from this new prioritization and rejection of funding is not known. Next slide. So our objective was to determine the 10-year clinical consequences of HIV resource reallocation scenarios in Tennessee. So as an overview, we're going to use a simulation model that's been validated to the natural history and care continuum of HIV in the US and in Tennessee. And we're going to use that simulation model to simulate patients individually. So Tennesseans at risk for HIV infection and Tennesseans living with undiagnosed HIV over the next 10 years. And using that model, we're going to compare two different strategies. The first strategy is the CDC strategy, or what the CDC was doing, allocating funding for condoms, PrEP, and HIV testing to persons at higher risk for HIV. And we're going to compare that strategy with the reallocation strategy. So taking those funds and reallocating it to HIV testing and linkage and first responders, pregnant people, and victims of human trafficking. And the data that we're going to use is Tennessee-specific data on the HIV care continuum and natural history of HIV. You can go to the next slide. So working with the community-based organizations and clinicians and policy experts in Tennessee, we kind of put together what we think may happen with the reallocation. So you'll see in this table on the far left, the different risk groups or populations that we're going to be simulating. The top populations are those who have been traditionally prioritized by the community-based organizations for HIV prevention. And the bottom three groups are those that the governor suggested prioritizing. And so we were able to estimate the amount of changes in condom use, PrEP, and HIV testing and linkage to care from this funding reallocation. So you can see that condom use, PrEP provision, and HIV testing in the at-risk populations will go down 4% for condom use, 62% for PrEP, and 60% for HIV testing in those priority populations. Whereas in the new populations, HIV testing will obviously increase, and we are assuming that a large proportion of those funds will be may be dedicated to linkage to care in pregnant persons and victims of sex trafficking. You can go to the next slide. So these are just looking at numbers of people with HIV and those who are diagnosed in Tennessee. This is similar to what Dr. Onkei have just been presenting from the AMFAR figure. So we see the predominantly people with HIV in Tennessee are men who have sex with men. So 12,000 men who have sex with men have HIV in Tennessee, 1,400 people who inject drugs, 1,700 or so transgender women, and 2,200 Black heterosexual women. And that we would compare to the first responders, to this new priority population where only 26 first responders have HIV in Tennessee. Next slide. Here's the incidence of HIV that we're using. So there are 480 new infections in men who have sex with men every year in Tennessee. And, you know, about 40 to 70 in the other kind of priority populations, and only one new infection among first responders in each year in Tennessee. And we used the model to estimate HIV incidence over the following 10 years, following historical trends. And then we plan to adjust that incidence for the reduction in condom and PrEP use in the reallocation strategy when we're simulating what may happen if those CDC funds are reallocated to the first responders, pregnant people, and victims of sex trafficking. You can go to the next slide. So really, this has been an effort in kind of rapidly assembling what we know and what may happen in an emerging policy landscape. And we're working right now very hard to use the model to simulate the differences in HIV transmissions, deaths, and life years between the strategies, and validating those results with our partners. So we're not going to present, you know, numerical results today, but we can say that in general, there are large disparities in HIV incidence amongst Tennesseans, which we saw in the previous slides. The CDC funding comprises a large proportion of HIV prevention funding to those at-risk populations. So we saw maybe 60% of HIV testing and PrEP provision is directly funded from the CDC source. And lastly, we've seen even in our preliminary analyses that reallocating HIV prevention funding away from epidemiologic risk groups increases overall HIV transmissions and deaths in Tennessee. And we're hoping to kind of get those results as soon as we can, validate them, and kind of disseminate them to give a peer-reviewed and quantitative estimate on the potential impacts of what this could look like in Tennessee, for both Tennessee and potentially other states that may be considering doing something similar. Next slide. So in the last couple of minutes, we wanted to just kind of give another story and some results that are from a similar perspective, and kind of show what the model might be able to show in the Tennessee situation. So in this paper, which was published a number of years ago, we compared a current PACE strategy in the United States, or kind of the current trajectory of linkage and retention to HIV care in the US, to the national HIV/AIDS strategy targets, which were very similar to the kind of 90-90-90 targets of 90% people with HIV diagnosed, 90% linked to care, and 90% of those virally suppressed. Next slide. And what we're able to do using the model, these are graphs showing long-term or really 20-year HIV care continuum. So the percent of people with HIV in the US who are unlinked, the percent on ART, and the percent suppressed. And the solid blue line is for, you know, the current PACE, and the dotted line is for achieving those NHAS targets. And you can see that the NHAS strategy had many fewer people unlinked, more people on ART, and much higher viral suppression. Next slide. What we were also able to do in this analysis was look at these outcomes in particular for Black men who have sex with men, which are a population that is particularly, has a particularly high incidence of HIV in the US, and has some disparities due to systemic racism across kind of all parts of the HIV care continuum. And we were able to see that in those red lines that the NHAS strategy would also improve outcomes for Black men who have sex with men. Next slide. These are some numeric quantitative results that are similar to what we're hoping to get in Tennessee. So you see in the general population, nearly 300,000 transmissions averted, 80,000 of which were in Black men who have sex with men. 200,000 deaths averted and 2 million years of life saved by achieving these NHAS treatment targets in the United States. And a real finding of this analysis, if you can go to the next slide, a real finding of this analysis is that when you take into consideration the cost of HIV treatment and the cost of providing these services, it's more economically efficient to prioritize HIV prevention and treatment and linkage scenarios in Black men who had sex with men. It was more cost effective with a lower incremental cost effectiveness ratio at $38,300 per QALY compared to trying to do this in the general population. And so I think that these preliminary results highlight that targeting, public health interventions to the populations who have higher incidence and kind of some disparities in care can actually be more economically efficient than trying to prioritize an entire population. Next slide. So just want to thank everyone, especially those who are on this call and have been working with us in Tennessee and the collaborators at CPAC and MPAC. And I think now we transition to Dr. McNamara for Q&A. Thanks, everyone.
Hi, everyone. So we're going to just do one question. I hope it's okay if I direct this to you, Mandisa. Mandisa, you're our only lawyer here, really. And unless
I am, I thought Liz was, sorry.
Oh, I'm sorry, Liz. I'm so sorry. I guess I've just had so much more contact with you. And you're also so deep and buried in the South and kind of like where these fights are being fought. And we've heard so much research broken down today, so many compelling results to us as clinicians and scientists. But I guess I'm wondering, how can this work be translated for the Fifth Circuit, for instance, or for powerful legal audiences?
Okay, thank you for that question. So, and I should have said this, but in the interest of time, I am an attorney. CHOP is a national organization, but I'm based in New Orleans. So I'm actually a practicing attorney in the Fifth Circuit. And the thing like that I would say is, as long as our only strategy is legal, it's going to be the same outcomes. Like I think the two women who talked about the work in Tennessee, like have really outlined how it can't just be a court-based strategy, like it has to be advocacy around with the insurance commissioners in each state, as well as lobbying, which I'm not saying that 501c3s need to do, but like whoever like the appropriate people are to do that, to private insurers, like to make them clear that it costs you less to keep preventative services covered than it does to insure the diseases. So like that kind of work needs to happen simultaneously. So as a lawyer, it is my advice that this never just be a legal strategy. It has to be done in conjunction with folks working outside of this one court case, not because it's not important, but because that's historically never been how things are won, is this one strategy. Something that I think is very helpful in Braidwood is the time that we have. Knowing that it's been stayed, knowing that it's going to take a while, like as far as for the Fifth Circuit to hear it, it's likely going to be appealed to SCOTUS. That's going to take a while. That's the timeline we need to be organizing and supporting folks on the ground in the institutions and doing what we have to do outside of just the legal scheme. With that said, I also think this is the moment to be bold. I think historically, and there are some reasons why we are very worried about such a conservative court having access to like broad ways of thinking. And at CHOP, as the leader, I'm the first to say, we have nothing to lose by taking a conservative approach. We know who's impacted. So our language has to reflect, this is not race neutral. This is not gender neutral. It's targeting certain populations, and that's part of how we got here. And so just saying what it is. So I hope that answers your question, but yeah, I'm sure Liz has thoughts as well, and others.
I think that is a wonderful note to end on, summarizing kind of the thrust of what many of our speakers touched upon today. I want to thank again our speakers and the moderator and all of you who joined to listen today. I think we could have continued the discussion for probably another hour at least. The recording will be posted on the CFAR YouTube channel. Many of the speakers have provided their contact information in their slides and in the chat, so I would encourage you to reach out to them with questions. Our hope from the CFAR is that this has sparked those listening to consider how their work, whether it's research and beyond, can inform these kinds of policy decisions and get involved in real time. And an announcement that the next CFAR Grand Rounds will be Friday, June 9th, 8 to 9 a.m. Cardiovascular disease in people with HIV, novel mechanisms and new HIV prevention strategies with Steve Grinspoon. I want to thank all of you again sincerely for your time and have a good afternoon.